definitely a gene, a genetic component to prostate cancer cases that run in families. Many cases, though, don't run in families. And so I would say it's a minority right now, but the only reason why it's a minority is because we don't have a full genetic understanding of prostate cancer. A lot of times there are changes in genes that simply they're not measurable well and not yet, that relate to the way certain products of the genes are made in our body and the way that they fold. And something folding different might still have the right gene, but it's folded differently, and that might be a risk for prostate cancer. So there will be, I think, over the next generation or two, a revolutionary appreciation of genetic abnormalities that cause subtle problems or problems only in combination with several other subtle problems that lead to prostate cancer. But ultimately, for any cell to develop cancer, there has to be a genetic change, whether it's caused by the environment or by stress or by inheritance. There has to be a genetic abnormality for a cancer cell to develop. Right now, the minority. We have been thinking more and more in our community programs about whether to offer genetic screening for prostate cancer. I think that's a little bit of a second concern to just getting people checked for PSA. But for those who are willing to look at that and participate in that genetic testing, that's pretty readily available with a blood test as well. I do, for the sake of being complete, I want to say a few things about treatment of prostate cancer. And this is a discussion that takes an hour with one person. So I am only going to mention the sort of general, okay, treatments for prostate cancer. First and foremost, the question is this a dangerous prostate cancer? We know based on the biopsy, and the PSA can also be used to make that assessment. But based on the prostate cancer grade, that's what the person looks at on the biopsy under the microscope. They grade the cancer, and they come in two categories of grading, I might as well say, for this meeting. And it starts to get complicated quickly. Okay. One is called grade group. It goes from 1 to 5. 1 is not dangerous. But for all Gleason, that's the name of it, grade group 1 patients, I tell them, do not be treated. Do not let anyone else tell you to be treated. I promise you this is not a problem. We just need to monitor it and make sure that nothing worse is hiding there or ever develops there in the future. For 2, 3, 4, 5, they're increasingly dangerous cancers. And the discussion is very different. The other category is it's actually 2 numbers that are added together based on what the person sees under the microscope. And the numbers go from 6 to 10, but it's really the same thing as 1 through 5. So there's Gleason grade or Gleason score, 6, 7, 8, 9, 10, just like 1, 2, 3, 4, 5. These are the things that show up on the reports that people read, patients read when they come back, and patients need to know about, especially patients who have the 1s, because they must not be treated. When we have conversations about treatment, it's for the Gleason group 2, 3, 4, 5s. There are 2 standard of care treatments for prostate cancer as of today. They are surgery and radiation. They are equally effective and very effective at treating the prostate cancer. And we tell most patients that they have an 80% cure rate 10 years after treatment with either one. So it's very treatable. That's about as good a number as any cancer has, except for skin cancer. There are new treatments that are being developed. There are new techniques for the ones that already exist being developed. And the new ones tend to be marketed very heavily direct to consumer. And I think that we have to have a word of caution about that. Some of them are effective if applied at a place that is experienced, or in the context of a clinical trial. Things that have words like HIFU, high intensity focused ultrasound, or cryotherapy, or TULSA, or TUCAD. There's all these names out there. It just gets wild pretty quickly. But I would not consider any of them standard of care treatment at this point in time. Right now, it's surgery and radiation. Right now, both surgery and radiation treat the entire prostate, not just the cancer that's in the middle of it, but the entire prostate gets treated. And that's because there are smaller tendrils or spikes of cancer that can stick out from the main cancer. So if we just go and carve out one little, marble, we may miss cancer. We know that there's usually more than one cancer in somebody's prostate. And we also know that it grows these little branches. So the entire prostate has to be treated. The prostate is not like having an appendix. Treating prostate cancer has major implications for urinary symptoms and for sexual symptoms. And all men need to know about those as well. There's no treatment that spares those. With surgery, what tends to happen is that the patient, if they're functioning normally up front, surgery really hits them hard and things get better over time for just about everybody. With radiation treatment, people are functioning normal at the start. Things tend not to have a big problem up front, but over time, things tend to get a little bit worse. So there's no path through this that doesn't require a conversation about the impact on urinary and sexual symptoms. And that's what a lot of men use to make their decision. They choose one versus another. It's choosing a bundle of potential side effects of risk of the surgery while also thinking about a cure.